Hello, I'm Dick Corsell, and welcome to Community Care Network Connections. Community Care Network is the overall parent organization of Rutland Mental Health Services and Rutland Community Programs, and this show is about featuring and highlighting the programs and services to Rutland County from Community Care Network. Today, my guests are Sue Rambo from Rutland Mental Health Services. Sue is the coordinator of Child and Family Outpatient Services. Karen Macaulay is the clinical supervisor for Children's Crisis. And Karen Grimm is the coordinator of school-based services for Rutland Mental Health Services, Child and Family Services. Welcome. Today, we are going to be talking about a program of child and family services called Trauma-Informed Care and the ARC model. And what we want is for our viewers to have a better understanding of this important service that's provided to this community, and so they have a better understanding of it and how they could access these services if they're needed. So I'm going to start actually with Sue, and we're going to just basically start with you telling the viewers a little bit about what ARC stands for and what the program is about.
It's about treatment of trauma. As I've been thinking about it, I've been doing community mental health for 20 years, and one of the things that you do a lot of is working with families and individuals who have experienced trauma. And one of the things that we know about trauma is the way it impacts individuals, and it impacts them often in attachment, which is what the A stands for, their relationships with other people, their ability to trust people. R, which is for regulation. They often have difficulty regulating their emotions, dealing with how they interact in their relationships with people. And then C is competency, their ability to feel successful, feel good about themselves. Trauma often has a negative impact there. So those are the three things that though ARC stands for, and then it works to try and address those areas by repairing those areas of attachment, emotion regulation, and competency.
Okay, good, thank you. I'm going to ask Karen Macaulay. We hear a lot about trauma. This is something that is in the news, you know, being very recent with the tsunami in Japan. We're hearing a lot about what trauma means to both the community and at the individual level. From a mental health perspective, from your perspective as a clinician working with Rutland Mental Health Services, what is trauma from a mental health standpoint, and how does it sort of relate to this ARC model and program?
Okay. Start with a little bit of history because it's really evolved over time, and it's interesting that you mentioned the tsunami because when I think of trauma, a lot of people will think of PTSD, post-traumatic stress disorder, which really became known at the Vietnam War when all the vets were coming home and having a major hard time fitting into society. And then I think of the recent wars and with Vermont having a lot of the reservists come home, and what a different response that they're getting as they realize that this isn't easy. That car backfiring, they're acting as though somebody's shooting at them. The vets are always on edge and on control, and have a hard time fitting back at times into civilian life. So that's kind of how a lot of it started with trauma, and then of course there's the natural disasters, the tsunamis, the hurricanes, the earthquakes, and then in the mental health field it really kind of evolved looking at trauma within the family, that often young children who have been severely neglected or abused at a very young age put up for adoption, that their ability to attach, as you were talking about, to their mom or that caregiver figure was really disrupted. So the initial focus of treatment was on, well, we need to kind of help them attach. The diagnosis given at the time was reactive attachment disorder. It's since evolved into really a proposed diagnosis of complex trauma, which really looks at the whole area of not just the attachment, but the ability to regulate, the ability to feel competent, which the model addresses. So complex trauma is really exposure to ongoing chronic events, which really overload that child's capacity to cope. It often means that there's some severe threat to their safety and security that they feel. The big difference between complex trauma in kids and families from PTSD or reactions to national disasters, that it's within the context of the caregiving system. The vets go over into war, experience a lot of trauma over there, and then come back. Whereas your kids, you're trying to raise kids in a system to give that nurturance, the consistency, the routines, the attachment, the attunement to, when you think of like the little baby and the mom, repeating back or going back and forth. So, and they can't escape that. These are the folks that they're supposed to be depending on, yet there's the same folks that are often not able to provide for their basic needs.
And also often have had their own trauma histories. Yeah. So sometimes this is multi-generational, that it extends back so that for them, they also have difficulty knowing how to parent or what to expect themselves. So it often is really complicated.
I was going to jump on that as well. It's about the layers and layers and layers of trauma in these family systems that we're dealing with. So it's not only the initial trauma of living in a home where there's chaos or neglect or abuse. We're talking about caregivers or grandparents that they themselves experienced trauma, so are easily triggered by traumatic experiences within the child that will escalate them. So.
And when it happens at a young age, often some of the normal developmental processes don't happen as quickly or are really affected. And my expertise is not the brain, but that's often where their functioning can be impaired. If there's, think of like kind of Maslow's hierarchy of needs, if you're struggling for your basic survival, you're not going to be able to be in the thinking mode. And there's a lot of ways that trauma affects kids. So you see a lot of these behaviors that you may not think, oh, that's trauma, which is part of our effort to, kind of really enlighten everybody around that. So whether some of it is the tantruming, major reactions to small events, something that's like, okay, what's happening here? Difficulty with transitions is a big one. Kids can be very clingy, dependent. On the other hand, they can be very standoffish, not have a good sense of boundaries in terms of how close to be or who's safe around them, who to go up to. Often cope by trying to be controlling in their out of control or very chaotic and unpredictable environment. Often a lot of fears or nightmares. So you see some of the same behaviors that you see in the PTSD with the nightmares, the intrusive thinking, that kind of thing. If they've had some of their, they maybe haven't gotten the nutrition early on, they may develop some hoarding behaviors. They collect food. They're always afraid, when is the next meal going to be? Often a lot of real impulsive or risky behaviors. Often not able to have much hope for what's in the future. And often a lot of, when I think of the pediatrician's offices, often it can be a lot of medical or physical complaints, or they're down at the school nurse all the time. The chronic stomach aches or the headaches, and it's like, you try and diagnose this. Well, it's really the stress in their way of manifesting what they're going through.
It's good that you're pointing out, because as we just were talking about, often when we hear the word trauma, we're thinking something major or one singular event that could cause that, like the tsunami, for example. What I'm hearing you describe, in particular the life of a child, is that so many precipitating factors, including divorce, probably substance abuse in the family, domestic violence, neglect in all of its forms, could very well create these complexities. Let me ask Karen Grimm, how does the ARC model work?
Well, I think, again, it creates a broader stroke, a broader lens for people to work and create a common dialogue. Part of our work in coming here today is to create a trauma-informed dialogue so that people in the community of Rutland are thinking more in terms of talking to each other, recognizing trauma, creating a lens, talking about supports, really understanding trauma. So it works by bringing us into a dialogue with various school providers, various other clinicians in the community, nurses, doctors, various other resources or systems that schools or children are involved with. It's a way to create a framework to begin to talk about trauma with people.
So let me ask you, who is the ARC model, the trauma-informed care ARC model, designed for? And we just heard Karen Grimm talk about reaching out to other providers in the community, school systems, other clinicians. Who's this model really aimed at specifically?
It's really aimed at everybody.
Yeah.
It really is aimed for children, for families, and also for people who are trying to work with children and families. The nice thing about it is it's very supportive of families. It's not blaming. It's an easy framework to enter into. It's not rigid, so you can kind of move it around as it sort of fits the family or the child. I think when anyone works with traumatized people, it can be pretty overwhelming because you're sitting with a lot of very intense pain. And so I remember early on when we were first introduced to this, we had a big staff meeting and I asked people, so how many people here have clients who have experienced trauma on their caseload? Every single person in the room raised their hand. And then I asked, how many people would be interested in learning how to effectively treat those clients? Everybody raised their hand, because it can be very overwhelming and difficult because you're sitting there with that and you're thinking, I want to help, but I don't want to make it worse. So I think the model works very well in giving people a sense of direction, a way to go, and then I think, as I said, it's very user-friendly for the family and for the child.
Right, and Sue, I was just going to add on, I think because we've been doing mental health work here in the community for so long, I think it gets us from thinking so rigidly and, oh, it's got to be an attachment issue. If we only work on reactive attachment, that will help. Or if we get to the story of the trauma, that will help. And this really gives students and kids and families more of a way to cope and get through life, rather than just find the answers all the time.
I think its other advantage is that it allows you to approach the trauma in a more compassionate way, because I think oftentimes we get well-meaning people who will bring us children and sort of want to plop them down next to us and say, okay, tell your story.
Right, and if you tell the story, then then we'll be working on the trauma.
Suddenly the trauma will get resolved, or at least come
but
to the
the last thing anybody is going to do is walk into a room with a stranger and spill their guts.
And if they do, you worry about it.
Exactly.
That would be re-traumatizing to ask people to do that.
Right, so this allows you to come in with, I think, a much gentler approach, helping put in, strengths and protection and ways to kind of gently move in that direction,
and
which
giving
is
the empowerment back to the kids and families rather than making them feel shameful for their stories. I think it allows them to feel some control in their life because they begin to recognize what their triggers are. They begin to recognize what helps them cope. They begin to recognize that I'm feeling dysregulated, I need to take a walk. It gives more power back to a person that has had trauma.
And I think one of the biggest impacts of trauma is the feeling of having no control. So this really helps hand that back.
So again, it's a framework. It's not, it's not set in stone. It creates a pattern to work with kids and families.
Well, let's follow up, Karen, since
Yes.
you were just talking about that in terms of where you're using the ARC model. And is how do people access it? In other words, let's give example. You do a lot of school-based work.
Correct.
You're a specialist in working with the
I
school-based
don't know about specialist.
population.
But I am out there in the community.
You're in the community,
to
you're
all
in the
the
school
schools.
systems, you
Correct.
know a lot about
Yep.
that
Yep.
population
Yep.
and that community. So how does this begin? I mean, where
Well-
would you find yourself using the ARC model?
Well, I was just meeting with the superintendent today and talking again about the effects of trauma. It's not just looking at the students that they're doing fine between the hours of 8 and 3, but looking at how trauma impacts learning. It has been found that trauma definitely impacts a person's capacity to learn. It definitely impacts brain development. It definitely impacts a person's ability to connect with peers, social skills. So how we've been doing it is I've been going out and talking to schools and superintendents and guidance counselors and psychologists to talk to them about, hey, budgets are tight, schools are tight, we're all tight, but there's a lot of trauma out in this community, and if we don't join together and talk about trauma and recognize it impacting our kids and families, then we're doing a great disservice. So it's really about, as you're having us here, Dick, getting the word out to schools, to families, to providers, to caregivers, to DCF. We've been to the Boys and Girls Club, getting people to have a trauma-informed dialogue, and so we all can be on the same page.
That's great to know. Karen, I want to follow up with you in terms of what Karen Grimm had just described with respect to the outreach. And we talked a little bit about a team approach with the ARC model. Could you talk a little bit more about what does a team approach mean, and what does it look like? What is that actually? How does that manifest itself in this model?
Many heads. Well, I think it's something you said, Sue, in terms of just the impact, you know, on the caregivers of sitting with that pain. And so again, you know, you can't do it alone. And I think that's probably why the three of us also work in a community mental health agency, because we like that teamwork. We team anyway in terms of we meet, like your team meets together for group supervision. Our two teams meet together. You work with a supervisor around this. And again, it's having to look at that impact on us and taking care of ourselves so that we can best help others take care of themselves. We talk in terms of building consistency, routines, and rituals. So you have to get everybody around that family and that child, involving them around what's a consistent response. You know, how can everybody understand what that behavior means and the function behind it and how it's related to the trauma? How can we give them that support that they need? A lot of it is educating the families around some of that. We run a caregivers group. A lot of it is coordinating with the other people, the schools. DCF might be involved, probation, parole. So again, if we can all be on the same page, we can hopefully help these families learn a different way to interact so that they can support that child and meet that child's needs.
Sue, let me ask you, kind of follow up all of these, sort of lead from another. This is a program of Rutland Mental Health Services, which is the community mental health agency for Rutland County. Who else do you collaborate with? Because I've heard Karen and both Karens talk about collaborating with others, whether they be school systems or other providers. But who else do you bring into this process once you have perhaps identified a child or family where the ARC model may be appropriate?
Well, most of our staff has been trained in the model, so...
And the state of Vermont.
Yes,
you
that's
should
the other...
mention the fact that this is an initiative brought by the state of Vermont 3 years ago.
Right.
So
we've been doing
all
this.
the designated agencies in the state of Vermont are trained in this model and using this model. So it's a bigger
It's a much
team
bigger than just us.
Yeah.
Yeah, which has been really very exciting. We've been part of this for, I think, 3 years. We're currently part of a 3-year grant with SAMHSA, which is a federal organization. And we're in the 2nd year of the grant, so we have another year after this one. doing this particular model. And one of the very interesting things that has been going on is that all the other agencies in the counties of Vermont have the same model that they're working with. So we are able to share the same vocabulary back and forth.
Right.
We're all aware of this model. So if we have families or children who are going to Howard Center for an assessment bed for 30 days or a step-down program, we can all talk together and use the same form system. Yeah, so it makes it very easy and quite exciting because that doesn't usually happen. So that's one way that we can bring it in. We can bring in larger resources outside of just here. We use a lot of assessment tools when we're working with families and children, so it's not just us sort of looking at it and going, this is what we think. We actually are doing assessments that are, what do I want to say?
User-friendly.
User-friendly, yeah.
And providing us information that maybe because the trauma has been so significant, families are ashamed to give.
Yep.
And so sometimes this assessment tool gives us another viewpoint to work with
an
the
easier
family
way
or
in.
kids.
Yeah.
Well, and I think some of the assessment tools are for the child. You know, what is their impact, their trauma and the impact of that and then their functioning, but we're also looking with the caregivers. So giving them, you know, kind of like their stress.
Yes.
You know, and then measuring this over time and seeing, you know, our goal obviously is that the caregiver's stress would go down, the child's ability to function would go up, and that we can see some measurable results in that.
Right. Yeah, so that it's more evidence-based, that we're actually measuring it, looking at it, assessing it. Are we making a difference? Does this have an impact? Does this shift what's going on in the family? Are we supporting the parents or caregivers enough so that their stress level's going down? Are they beginning to see the child in a different way, a better way? Are they seeing themselves differently in a better way? Do they feel more confident about being a parent? Are these symptoms that the child is exhibiting with the trauma getting better, getting worse? What's shifting here? So it's something that is something we can look at, we can measure, we can assess, and sort of tweak as we go along.
So it sounds like the Vermont, the designated mental health agency system, is very powerful in that respect as it relates to this program, because this is something that the agencies are all working on together for the betterment of the state of Vermont. And it sounds like you're able to access the expertise of other providers in the other mental health agencies and vice versa. I would imagine that the three of you are consulted on a regular basis from other mental health providers in Vermont because of that relationship.
And the training was done by the Trauma Center in the Justice Resource Institute in Boston. And one of the founding trauma gurus was Bessel van der Kolk. And we're learning we're learning a tremendous amount from just their work. Then the name of the person that trained us is Margaret Blaustein. And she came up to Vermont at various times throughout the years and is training us directly in dialogue and looking at cases, and again, it's all the state agencies again looking at trauma.
Some of it's a grant, so what they've also built in is when this grant is done, how does it keep going? So, and again, this isn't that we all went to a 2-day workshop and that's it, but it's monthly consultations with Margaret on the phone, every single agency, presenting cases, going through the model, and a lot of ongoing education on Margaret's part to everybody. These two ladies have been part of 4 that went up originally and got trained extensively, and from there it's like then they really incorporated a bunch of us in terms of kind of getting on board, being excited. All of our clinicians now have that training. The other thing is that Sue and Claudia, another ARC person, is you guys are also getting trained to be supervisors. So when Margaret bows out, we have that internal resource as well as what we can provide to the community. I went to a training with 2 other folks on really train the trainers, in other words, helping us to how do we train the community, not so much in the treatment model, but just the impact of trauma so that we can be a trauma-informed system of care, whether that's from the pediatrician's office, the emergency room, the school, DCF, whatever. So
let me ask you in just the last few minutes that we have, for a viewer that may know of a family or may be experiencing this very issue, this trauma issue with their child or someone that's close to them, how should they go about accessing service? Who should they contact and how?
Intake. Part of my many hats. They just need to come in through the regular intake process at Rutland Mental Health. And then part of that assessment is what's going on, and then the clinician meets as part of that initial intake assessment in terms of some recommendations. That can be
part
through
of
the
our intake is even more looking at trauma too. We're asking more about trauma in our intakes.
Right.
So I think we're even more sensitive to trauma in our intake system.
Yeah. And whether that's the young kids team, the kids from birth to 6, whether it's, as we call the old kids team,
Yeah, the big kids team,
the
right?
6 to 18, or whether they're coming in through the school system. We also have the jobs program and the youth in transition. So really, no matter which door you enter through Rutland Mental Health, it's part of, you have access to people that are trained in this, and we're assessing for it and, supporting each other in it.
That's an important point, and I'm glad you said that, because that's really the purpose of this program, is to really educate the community about the multidisciplinary approaches of this agency, Community Care Network, Rutland Mental Health Services, and Rutland Community Programs, all part of the same family, and all of the programming and expertise that is weaved through, that you may have other counterparts within the agency dealing with a family or child perhaps in a different dimension for a different issue. But the issue of trauma very well may come up during that period of time, and the fact that you're able to network internally within the agency, but also externally, I would think would be a great benefit to all the families that we serve in Rutland County.
Yeah, we do offer a variety of levels of service. So, depending on the intensity or the need, we have, the outpatient services, which are the traditional office-based. We have community-based services, which are available, case managers that go into the home that help support some of the things that you might be working on in the office. Or we have intensive family-based services, which are clinicians that actually will also go into the home and help support families in trying to deal with some, very intense things that are very difficult. We have the school-based services,
which are growing profusely.
So,
so schools are becoming more trauma-informed and wanting those services right then and there.
And having, kids who may need individual support during the day because
they
of the trauma that's interfering with their ability to function. So they need somebody who's really kind of their one-on-one person who understands, again, what trauma does and can help them with the transitions, with their peer relationships, just, those kinds of things.
I think just one other thing, I think the more trauma-informed this community can be, the more we can keep kids in our community, rather than thinking that these children are beyond our control or beyond our scope of being able to help. And
that keeps costs down and outcomes better for the region and the community.
It's better for kids.
Sue Rambo, Karen Macaulay, Karen Grimm, I want to thank you,
Thank you.
For being on Community Care Network Connections and talking about trauma-informed care and the ARC model. If you would like to learn more about Community Care Network, please visit our website at www.rmhsccn.org. I'm Dick Corsell, and you have been watching Community Care Network Connections.